This section offers Acumed's suggested method for implanting the Polaris PHP proximal humeral plate. For specific questions not addressed here, please contact your local Acumed representative or contact Acumed directly at either 888-627-9957 or on the web at www.acumed.net. The patient is placed in a beach chair position, and the arm is draped to aid with fracture reduction. Create an entry site for access to the proximal humerus through a 10 cm standard deltoid pectoral incision made obliquely, in line with the deltoid pectoral interval. As an alternative, the incision may be made in a more longitudinal direction, starting at the level of the acromioclavicular joint and extending distally. This approach may potentially be more cosmetic for the patient. Sharply dissect down to the level of the fascia and elevate the skin flaps. Identify the cephalic vein and develop the interval between the deltoid and the pectoralis. Retract the cephalic vein laterally and the pectoralis major medially. Release the fascia along the lateral border of the coracobrachialis and retract it medially to expose the proximal humerus with a subscapularis tendon attachment. To help facilitate reduction and improve fracture visualization, release the superior 1/3 of the pectoralis major from the shaft. It is important to place a finger underneath the pectoralis major as it is being released to protect the biceps tendon, which lies directly underneath. Place the Polaris PHP 3 to 5 mm posterior to the bicipital groove and approximately 5 mm inferior to the top of the greater tuberosity. Confirm fracture reduction and plate height fluoroscopically. When proper reduction and positioning are obtained, provisionally secure the plate to the bone with a custom PHP Vabrouge clamp. K-wires may be inserted through the proximal K-wire holes and into the humeral head for provisional fixation. Sutures may be added at this time to improve construct stability. Due to the design of the 3 suture holes, sutures may be added upon completion of plate application. Insert a 3.5 mm bicortical screw to secure the plate to the shaft. The screw may be inserted through any slot in the plate distal to the fracture. Use the 2.8 mm drill guide and the short 2.8 mm drill. Determine screw length with a depth gauge. Using the 2.5 mm hex driver, insert the 3.5 mm cortical screw. The clamp may now be removed. Select the appropriate targeting guide and secure it to the plate with the targeting guide locking screw. The first proximal screw inserted will be a 5 mm non-locking cancellous screw. This helps draw the plate to the bone, affirming reduction and a low-profile plate-to-bone interface. Insert the 5 mm drill guide into one of the proximal holes of the plate. All proximal holes except the 5 mm cancellous screws. However, the first screw inserted is usually the center hole that borders the bicipital groove in the large plate and the most inferior hole in the small plate. Use the 2.8 mm drill either under power or by hand. Determine screw length by aligning the laser mark on the drill with the scale on the back of the drill guide. For accurate measurement, be sure the drill guide is fully seated into the targeting guide. Remove the drill and drill guide and insert a 5 mm non-locking cancellous screw through the targeting guide and plate. Insert the first proximal locking screw through one of the top holes of the targeting guide. These holes most frequently utilize locking screws because of their converging screw angles. Insert the fuchsia-banded clearance drill to open the near cortex of the proximal humerus. The fuchsia-banded drill guide is then inserted, and the 4.6 mm fuchsia-banded drill is inserted either by hand or under power. Determine screw length by aligning the laser mark on the drill with a scale on the back of the drill guide. For accurate measurement, be sure the drill guide is fully seated into the targeting guide. Remove the drill and drill guide and insert a fuchsia 4.5 mm locking buttress screw through the targeting guide and plate. Prior to inserting the locking screws, be sure to confirm that the fracture is reduced anatomically. The locking buttress screws do not produce a lag effect that draws the plate and bone together. Using the same process, insert the remaining proximal 4.5 mm locking buttress screws. In osteoporotic bone, the non-locking 5mm cancellous screw may be replaced with a 4.5mm locking buttress screw. Insert the remaining distal 3.5mm bicortical screws as previously described. Close the wound in layers with a subarticular stitch and place a drain for early post-op recovery. Post-op protocol. Passive range of motion exercises are initiated for the first 4 weeks, then active assisted for 2 weeks. Active range of motion and strengthening are started at approximately 6 weeks postoperatively when fracture healing is evident on radiographs.